Safe are digital consultations? It's a question that many people have repeatedly been asking. We're finally getting some data coming out about this. And in this episode, myself and Andy are going to analyze the Health Services Safety Investigation Bodies report on digital consultations in general practice in terms of what they think is good, not good, and can look better as we tech enhance your primary care and learning. Hello, AGP learners. Welcome to this episode where we're looking at a pretty new report that talks about online consultations in general practice and whether or not they are safe. How are you doing there, Andy?
Yeah, I'm pretty good. Another busy week, Andy, but interesting to look at another report from this agency, the Health Services Safety Investigations Body. It's a new agency set up in October 2023, and I think we have looked at a
Really
report
new.
from them before. I'm trying to remember what it was about, though, but we have introduced this body to people before. So they're an arm's length, independent, fully independent body, but funded by the Department of Health and Social Care. And their remit is to look into patient safety concerns that arise through the functioning of the health service, and to do sort of quite in-depth investigations where sort of thematic analysis has investigated, has identified potential concerns in areas. And they've just released a report about online consultations, which is something that we talk about a lot. So I think it's really good to have a look at this report.
Yep. And it's quite an interesting one because one of the things it does mention is it looks purely at the safety of online consultation. It doesn't look at the overall benefits of online consultations and things. So I think it's important to, as ever, when we look at these kind of things, look at the remits and stuff. But I suspect this will take the framework for moving forward with online engagement with patients and various other aspects of digital first consultations and things for practice to consider. So it'd be interesting to see where the impact of this report ends up in the coming weeks, months, and potentially even years, I guess.
Yeah, I think so. It's a really interesting report. I think it is quite balanced. It's not particularly sensational, and there is advice from the report, sort of aimed at lots of different levels. Actually, aimed at practices in terms of selecting their online tools, at ICBs in terms of how they support practices and how they support good procurement of online tools, and also for those organizations and companies that are producing these online tools as well, in terms of how they produce them, how their interfaces work, and so forth. So it's really, really interesting. Shall we dig in?
Shall we? Well, let's bring it up on screen. So there we go. I'll put another way.
Okay, so you can find it on their website. They're pretty easy to find, and it's one of their published reports. Today we're going to look, because I wanted to highlight it, I've exported it as a PDF, so we'll be looking at it as a PDF for the purposes of today. Hopefully people can handle that. It looks a little less exciting. So those are all the areas of the report. It's quite long, so what we've done is I think we'll kind of just highlight. We'll jump to the highlights really. So this report has been produced following some concerns around potential hazards. That's the remit of this organisation, and they've had concerns from general practice staff and from patients about online tools, and so they've produced this report. Interesting, if you ever pick up one of their reports, we're just scrolling through to get to the good bits, but they define certain things. So in some ways, it's a bit like a legal document. And they sort of say, well, there's a bit of background actually that talks about COVID and the increased use of online tools during that period to support general practice and support patients. But they feel that now is a good time to start looking at the safety. And they're defining an online consultation tool as something that supports asynchronous communication between patients and the team looking after them. So I think that's sort of, we don't call them e-consults anymore because I think that's one particular brand, but it's those sorts of asynchronous online messaging consultations that they're talking about.
And just to explain what asynchronous means for those who are not sure, so that from their definition is a consultation that does not take place in real time between a patient and a healthcare professional may be provided by an online consultation tool.
And you know what? That might be a good time to, this is terribly low resolution, isn't it? But this is a diagram we might be familiar with because this came out at the time when they were introducing modern general practice. If you remember, that was part of the contract imposition. I think it was last year rather than this year, the modern general practice changes. But this flow chart was part of that. So if people are implementing online consultations or asynchronous consultations as per this guidance, it looks a bit like the patient identifies a need for care. Patient then completes an online request relating to their need for care. it is sent to general practice. Request is triaged, so not necessarily by a clinical person at this time, but it's deemed whether this goes to other members of the team for signposting or processing. So it might be very simple request around repeat medication, for example, or clearly could be signposted to a different organization, or it's passed to a healthcare professional who then reviews the request and then decides on broadly 3 types of outcomes, really. So it might be that further remote contact happens. They ask for a picture, they switch to a telephone call, they ask for more information in an asynchronous chat. They're given a face-to-face consultation, or they're then sort of discharged to another outcome, such as signposting to another organisation, which can be communicated electronically. So that's how it works. That's what we're talking about. So I think probably a good way to tackle this, Gandhi, is probably to dive in and look at just pick out some of the areas that they have looked at, some of the concerns that they've found, and then maybe jump to the recommendations at the end. So think about the types of concerns that are raised in terms of patient safety. So they describe a few cases, but they describe this case of sort of a delayed cancer diagnosis, where it looks like there's kind of 2 electronic consultations that have happened. So the first one, the patient's described a skin lesion. They've also disclosed a background history of previous skin cancer, and they've been referred appropriately, given that this was a non-aggressive type of skin cancer. They don't say what it is, but maybe it's an actinic keratosis or something like that. And they've been referred via an appropriate pathway that isn't a 2-week wait pathway. They've then submitted another consultation later, and forgive me if I don't get this quite right, but it looks like they didn't disclose there's a change in their skin lesion. They've not disclosed the previous history of skin cancer in that consultation. A non-clinical person reading that hasn't got the full picture, because they haven't been looking, I think, sort of at, they've not had access to the past medical history, or that's not apparent to them at the time when they're triaging it. That's been dealt with in a more non-urgent fashion, when actually it might have warranted a 2-week wait referral. I think in the end the patient was okay, and it's just a matter of process. But that's the sort of concern that they've had. And they've highlighted a few things here. It's multifactorial when looking at this particular incident, and issues around the design of the tool in the way that it gets information from the patient. How the tool worked with other digital systems. So I think there's an issue around integration, and how it displays information kind of next to, or does it display the past medical history to the person triaging it, and then how that's kind of integrated with the other processes around the referral that's already been made. So got a bit technical there, really. But do you share these sorts of concerns, Gandhi, about online tools, in terms of your experience with them?
I think it can identify some of the challenges when you use an online tool, and don't forget, any tool that uses a human interface will always have the potential for error. So it comes down to the level of information you get, the level of information that's understood, the continuity of that information, the process that comes from it as a result. You could say, why was the notes not reviewed on the second consultation going back? Why did the patient not mention it the second time? Maybe they felt they'd already done so and therefore didn't need to. Absolutely
Exactly.
appropriate in that sense. So I think there are multiple steps, but I guess the difference I would put with that is, how would that be any different to if a patient consulted with a clinician in person? Would that have been different in those situations? Some would hope so, but also I can guarantee you, I'm sure the MDU and other indemnity organisations that do exist would highlight many situations where exactly the same process has happened in a face-to-face consultation route as well. So I guess what I'm seeing from that is nothing that doesn't say to me it's not necessarily about the tool itself, it's about the way the tool is used.
Yeah, I think so. Or not about the kind of the principle. It's about the implementation, really.
Yeah.
I mean, what I would say is, I think if these were both face-to-face consultations, and if that second consultation was an old-fashioned standard face-to-face consultation with a clinician looking at the lesion and probably being able to pick up, that there is a change and that it looks suspicious, then probably the outcome would more reliably be, a prompt 2-week wait referral. But there's always flaws, with any system, isn't there? There's always problems, and it's all about how you use and apply that system, rather than necessarily the tools that you use. So other issues that they've sort of picked up on or raised from incidents is cues being missed around safeguarding issues. And I must admit, this is something that has always concerned me a little bit about online consultations, in terms of sometimes someone will come and see you and they've told the receptionist that it's about something completely different. And then when they come in, they make a disclosure that's sort of safeguarding relevant around domestic violence, or, other forms of abuse and coercion that they didn't want to disclose when they were making that appointment. And, I think that's a fair challenge for this appointment type.
And that's a difficult situation to be in. I guess are we saying the trade-off of what online enables us to do? That's one of the things we need to recognize is a potential trade-off. Does that mean that you don't have other routes? No, that's the point. You should have other routes into the practices as well to support it. And the term I've been using over the past few days is we've implemented a total triage system, is that every system should have a bend, and every system will probably have some breaks in it, because with medicine, there's always exceptions to the rule. So how do those exceptions last? And absolutely, safeguarding and capturing consultations is part of that. So it's just something to bear in mind. And obviously, again, it comes down to that implementation process, doesn't it?
I think so. For me, it's probably about providing patients with options, so that they can choose what they feel is most appropriate for their real problem that they're experiencing, and being clear to patients that they have options. And the other sort of large concern that they had was around over treatment. And I can fully appreciate how this happens, where you can't see, touch the patient, and you are managing risk around that patient's health and safety. You are creating a situation where you may be more likely to prescribe antibiotics or other treatment to help manage that risk. I guess we might always want to, you might say you can always convert to a face-to-face, and I think actually we should make it really, really easy to do that. But patients don't always want to come down, and, once you've made it sort of available that they might be able to get care remotely, a lot of patients like that, and they don't necessarily want to come down when they might be working or doing other things.
Absolutely. Off the top of my head, I have 3 patients that I can think of just in the past week who pretty much refused to come down, because they're like, why should I have to come down? Like, well, actually, we do need to assess you, because this is the second, third time you've had this problem. We probably need to be looking at you. I don't want to come down. I'm like, okay then.
Yeah, absolutely. And I think there'll be kind of marginal cases where doctors just come down on that side of maybe prescribing, just to manage certain risks. So I think that's fair consideration. They look at other things in the product. They look at the patient experience of online general practice. I just picked out one quote here. So it's very difficult to get a medical appointment now, and my surgery is pushing more and more services online. It's got to the point where access is so difficult. I don't seek advice and just hope minor conditions go away. So that feels quite extreme from a frustrated patient. But do you identify with that experience, Gandhi?
I think that comment speaks to much wider issues than just online tools. So as we know for a fact that general practice is going through an unbelievably challenging period, to the point where, if you saw our earlier video from last week, that actually, majority of GPs are asking for industrial type action based on the fact that there's just so many challenges and underfunding from successive years by previous governments and stuff and things. So actually, I think that is more of a flavor of the challenges that general practice is currently facing, rather than, again, the tools that we are talking about being the direct cause of that.
Yeah, no, I think that's fair. And I think it's also about the implementation and the involvement in patients in the implementation to make sure it lands well with patients. And we'll kind of get to that point in a little while, because that's an area that the report is critical of. But as we said at the start, the remit of this organization is to look at safety concerns, not to evaluate benefits or to balance benefits with potential safety issues. But they do have a little section where they say, actually, we've encountered some feedback which is beneficial in the course of this investigation that has been doing. So some patients actually quite liked the idea of having prompt responses from their practice team, and experienced that, and they felt that they got that. They felt that they got quicker diagnoses, quicker treatment. It was faster, more flexible, more efficient. So that's good, and that's backed up by some research that they quote as well. And then from the general practice perspective, many of the practices and practice staff identified lots of potential benefits, particularly sort of freeing up resources and time for those patients that can't use that route. So I guess in a situation where you are offering choice, some people choose the online route. There are efficiencies if the right people are choosing that for the right reasons, and then you can use liberated time to spend on other activities. So they felt that there were some benefits that they'd encountered.
Yep.
Good. And improved sort of just flow of patients in some circumstances.
I guess just again highlighting point 2.3.
Yep.
Yeah, so as they stated, so their remit did not look at the wider benefits of online consultation tools. So it was very much a specific view looking at patient safety and the pros and cons around that aspects, and not the cumulative and I guess the additional impacts that using online consultation tools may have. I guess I can reflect on various journeys that patients have had where it's been a really positive outcome because they've used online consultation routes, and admittedly a lot of those are not covered within this remit of the group because they are purely focused on safety, not outcomes as well.
Yeah, no, you're absolutely right. And so they're not purporting to be presenting a balanced view at all, not their role. But yeah, you're right. Actually, in some ways, combination of digital cloud telephony, being implemented alongside online asynchronous consultation tools. We've actually had some good feedback, actually coming through practice through our friends and family and compliments route, saying actually they like the changes. So it is popular and it does help some patients. So other things that they're looking at. So look, some patient perspectives. So what are patients saying about online tools? So difficulty finding the tool on the website or navigating the tools, difficult to use the tools. So concerns about language used, levels of literacy. There are concerns about translation services later on in the report as well, not having the right sorts of devices. For certain parts of the population, I think that is definitely a concern, or having the data to use them. People don't always have all you can eat data plans. Not knowing how to use or find the tool, and people who choose not to use the tool, they don't want to engage with digital healthcare, and that's a problem if your practice is really, really going for it. So those are some of the things that patients thought. Those are just things that we're picking up. The report's really good, just giving you a flavour of what's in there. They look at staff perspectives on the tool, so just picking out some specific highlights. Patients can find it difficult to describe their symptoms in writing. So I certainly understand that with some patients. And actually, when you review some some online consultations that you get, often you just say, I just need to speak to this person. I'm going to have to either call them or arrange for somebody to call them today. But that's a valid outcome from it. But that patient might have found it really quite difficult to get as far as they've got potentially. So I think it is a valid point. Patients might not disclose some symptoms. So yes, safeguarding issues, but also embarrassing medical symptoms, might be an issue there. And some concern about patients gaming the system. So the concerns that they're aware that if they give inaccurate answers to tools, that they can increase the likelihood of getting the outcome that they want. So I guess that could be a face-to-face appointment. It could be antibiotics. It could be other things. So concerns about people gaming the system. And I remember this was when Babylon Health were first using their sort of chatbot type pseudo AI tool in one of the London CCGs in a trial. There was concern then that patients were gaming that chat feature to get the outcomes that they want. So I think this is a feature that we need to look out for with these sorts of systems. So other highlights. So so the types of interfaces that they're using. So I don't know what your experience is, Gandhi, of the sorts of systems that you see, and you see a lot of them. But they're sort of contrasting free text with structured questions, and I often find the free text potentially the most useful part of our system, where the patient is expressing their problem in their words. And in fact, that's often my opening line when patients come in to see me. So tell me what's brought you in, in your own words. Tell me why you're here. And I think that's a Roger Neighbor, the sort of grandfather of of general practice consultation theory, that's what he says is a good opening question. So free text allows people to describe their symptoms in their own words, but also without prompts. Patients might leave things out. So actually, maybe a combination of those two is the best way to go. And then with structured questions that require patients often to ask a lot of questions. So on the plus side, collecting those prompts and presenting that information might support decision making, but also there's the risk that a patient is led down a particular path because they've mentioned one symptom and actually that wasn't the main symptom that they were discussing, or they've mentioned a number of symptoms and they end up going down a number of different branching question routes for each of those symptoms, and a lot of unnecessary and confusing information is captured that needs to be sort of clarified by the clinician. So yeah, what's your feeling of where that's done? If that's done well, Gandhi, what does that look like for you?
The thing I like in this too, so think of surveys and survey completion rates and efficacy in the information you get. The qualitative information you get much better qualitative information when you ask broad, open questions. When you want quantitative data, so data that gives you, hard facts and that kind of stuff, you ask the more specific, structured questions and things. The problem with medicine is that you need a combination of both, because you need that context from the patients and you need those hard and fast positives and negatives to help you manage risk. And therefore, having a combination of the two is absolutely the best way to do it. If you're trying to do that, it's no different to how we ask questions when we consult with a patient. As you mentioned, you start broad and then you narrow down to figure out the pros and cons, the positives and negatives that you need to focus on. So then you can come to a decision. My general view is that if you're using these as data capture, the free text are the better ones to start to use, and then you narrow down, mainly because what you don't want is people not completing them in the first place, which is where the more detailed structured ones can sometimes be an issue because people stop engaging with it and therefore you don't get the information in the first place. So what is better? Some information, no information, and when you've got some information, quantitative versus qualitative. And that's basically what they're saying, effectively.
Yeah, absolutely. Gandhi, I won't name the tool that we used, but I've seen structured questionnaire outputs that include things like the patient's shoe size. When they're describing, leg and foot issues such as swelling, and you read that, you just think, why? And this poor patient, has had to sit through this questionnaire. So I mean, we'll probably talk about patient engagement just in a minute, but there is some criticisms about the level of patient engagement by some of the makers of these tools in terms of, are they actually designed to be patient friendly or not? So just if we just look at some of the other highlights and then maybe go to the findings in a minute. So they give a bit of time to, and maybe not go into these in detail, but they give a bit of time to language translation and highlight that as an area where these could be beneficial, but could introduce risk if not implemented well. The integration with other clinical systems, particularly the GP's clinical record system, is really key in terms of the right information being displayed to the person triaging, and then the recording of that information into the notes. So that is, absolutely key. And then thinking about how artificial intelligence is implemented, and probably don't have time to go into that now, but these are obviously really important issues. There's thoughts about how these are procured, which I think is interesting and more relevant for ICB colleagues. And then patient engagement, probably the last thing just to dwell on. And actually said, so none of the patients the investigation spoke with recalled being consulted on local plans to implement an online tool or had the opportunity to influence in its configuration. And that's quite sad, but it probably doesn't surprise me a great deal, to be honest. What do you think about that, Gandhi? Do you think that that's probably true across the board, or are you aware of examples where there would have been good engagement?
I think historically that's definitely true. I think currently, there's a greater focus being put on to engaging with patients and co-production of how do you manage your appointment system. I know in our practice, so today my practice went live with total triage models and stuff, and last week I spent an hour and a bit doing a live stream and an open patient meeting for our patients, explaining absolutely every step of the new changes and why we're making them. Did I give them the choice of what tools we use? No. The reason for that being that that's actually a business decision, if I'm being brutally honest. However, I did engage
Can
our
your business
patient.
decision be influenced by your customers? Just a
Well, so I
helpful
was going to
challenge.
say that. So
Yeah.
before that, if you go back 2 months, I did present to our patient participation group, which was a focus group effectively of those, and showed them that these are the options we've got, and that actually we're using a tool now. Will we continue using that tool in the future? We don't know, but actually because of the journey we're going through, this is why we're choosing this one. And then actually, when we come to a decision of making others, we will actually go back to them at that point. But for now, actually, we need to stick with what we've got, because
Yeah, we
that's the
went through a similar
safer
thing
option.
actually. Yeah, we kind of showed the patient participation group what we thought we were
Mhm.
going to use, and why, and they sort of quietly sort of approved
Mhm.
of it. But I think we could probably do better in the future. It's difficult, isn't it, to show them a range of tools? You know, when you are just a small general practice business, you know, and actually maybe there's a role for ICBs to do this sort of work, but then also the small businesses that are general practice don't always want to be dictated to by the ICB, you know, about what tools they use. So it's a difficult
And I think
environment
there's
to
also
navigate.
understanding what the implications of the tool actually mean for the patient. The part the patient's going to engage with is the questions and answers part. So actually,
Mm,
that's the part that's relevant. If that works for the patient but doesn't work for the practice, how can you then make that effective? You know, for example, what if it doesn't integrate with your clinical system? It's an amazing tool for the patient. It doesn't integrate with your clinical system, so therefore, actually, you're even less effective. Those are the things you need to
yeah.
consider. So I think absolutely engagement is important with the patients, and taking them on that journey with you really important. But at the same time, there are certain aspects of particularly this report, I think, are just a little bit pie in the sky, if I'm being honest.
So key findings. So evidence the tools have benefits, but they also found some evidence that contributed to patient safety incidents. Um, Incidents are not always reported, so they're feeling that
Yeah.
reporting around these incidents aren't always reported, and that actually that is an activity that should be supported more. Some harm can occur when patients actually can't use the consultation tools due to their personal circumstances or use them correctly. General practitioners have not always had the right training to use the
Hmm.
consultation tools, and I think that that's right, and they're a new area of work, aren't they? Needs of the users are not always identified and incorporated into the design. So I guess we've hit on that by talking about the complexity of some of those branching question algorithms there. And general practice engaged with during the investigation had limited oversight and support from their clinical commissioning groups when procuring and implementing consultation tools. That's fine, but I guess on the other hand, they don't necessarily want to be dictated to. But support doesn't always look dictatorial, I think. And they acknowledge that it's a complicated project. General practice have to make some difficult decisions in how to procure and implement these things, and do they have the time and resources to do that properly? Have they
Hmm.
been given the right resources to make those implementations properly? And they've probably not really been given much resource at all in many places to do it. Limited patient engagement can really damage the implementation. And there's concerns around the increase in the effect on workload as well. The tools might increase it might increase current work and might further increase future demand by, they say, reducing opportunities to provide health promotion advice or manage long-term health conditions, which is often sort of something that also happens when we see people about relatively simple
Hmm.
conditions. So really interesting. I think, Gandhi, it might be worth us just thinking, what's your kind of general feeling about this issue around the safety consultation tools? Having spent some time looking at this report, do you have any thoughts?
I think increasingly these tools are being used in general practice, and I think there is an aspect of how safe and effective can they be. One of the things we know is that text messaging is not the safest way of communicating with patients because it can easily be hacked. But also, well, if you know what you're doing,
Yeah.
but also, have you got the congruity of the information? I think is the word I'm looking for. You know, do you know that what you're sending is going to the right person?
Mm.
And that they're seeing it and that they're not sharing with other people inappropriately or accidentally, I guess is the other thing. So, the communications you have with patients should be actually kind of non-specific and direct them to more secure options. So either contacting the practice back so you can confirm their details, or direct them, for example, the NHS app, which has the NHS login, which is as safe as you could be, I guess, from that perspective. Again, infrastructure, data availability, and all the other things play into that.
Yeah.
But I think the safety of the tools is always going to be a question mark. The question I've got is, what's the evaluation of not using those tools? No one, as far as I'm aware, has done a safety impact on what happens if you just suddenly stop.
Yeah, absolutely. It's not a balance report, is it? So it's not saying whether we should or shouldn't use them. It's providing some guidance about how we can limit harms through their use. So I think it's important to view the report in that context. I think it makes some really good suggestions, around all those areas.
No, it does. It makes some really good options in terms of what to look at and stuff.
So I think actually it's a good exercise to maybe watch this video and think about what that means for actually your practice, and if you go back and think, pick up this report and think about what that might mean for your implementation at your practice, and how well you've engaged your patient group, and whether it's time to re-engage patients on these decisions.
Yeah, I mean, maybe really worth quickly just mentioning those. I think it's 5 safety observations it's made, isn't it?
Shall we go through? I was wondering about time. So
we're gonna have to be quick. That's true.
Let's do them. I'll quick fire them. So right, further investigation. So they're advising more investigation into the safety of these tools. They're also recommending that they develop a mechanism for assuring that integrated care boards are providing the right support to general practice. So that's quite good for general practice, I guess, in terms of the implementation of online consultations. They're wanting better reporting of patient safety incidents associated with online consultations, which I think is very sensible. So national health care organizations can improve patient safety by creating the conditions within which online consultation tools can be effectively implemented, including ensuring general practice has the correct resources, capacity, and capabilities. So I think that's better resourcing, for this actually, which I think is really, really sensible. Consider how this works. So very good for acute, good for acute care, most people would say, but actually, how do we integrate long-term condition management into this? And actually, there's some examples of this being quite good for review of asthma and other long-term conditions, actually, in certain patient populations. But they're suggesting more consideration of that issue. How can we improve the software? By working with developers and getting developers working with patients to make it more patient safety. And then specifically for ICBs, they want ICBs to improve patient safety by involving general practice and patient groups in procurement, supporting general practice to implement tools that meet the specific needs of their patients, and ensuring general practice provides suitable alternatives to online consultation tools where they are needed. So providing the alternatives to make sure that people have other routes in, as we discussed around disclosing safeguarding concerns or other things which they might want to do face-to-face and not raise in an online environment. So those are the recommendations. I'm going to give you a hot take here, Gandhi. So I've sort of been saving this one up, but there's a lot of scrutiny of big pharma companies, in terms of how they promote the benefits of their products, which are largely drugs, aren't they? Drug interventions. Quite a lot of rules about that, and how they kind of work with GPs and and also politicians, and how they influence. And I've heard some people sort of saying, oh, maybe health tech is the next big pharma, and you look at the amount of sponsorship of events and things like that. And it just sort of strikes me that that might be something that we're talking about more in the future. So watch this space. But that's just a bit of a hot take for you at the end of this episode. Right. Anything else before we wrap up, Gandhi?
Well, I guess if people do want to watch how you could start doing some of this patient engagement for a total triage system, then absolutely check out this episode where I did exactly that. So it's a copy of my patient engagement meeting I had. And then I'm hoping to talk about some of the pros, the cons, and the negatives and stuff, and the things I forgot to do as well in an upcoming episode, which may be right here. And as always, we'll be here to help tech enhance your primary care and learning. We'll catch you next episode.
Bye-bye.